So our next session, all tracks are combined. Everybody's back in this room. Hopefully we will have everybody come back in. But we have our first set of speakers. And so we are actually going to have Dr. Scott Walter back again from Hartford, Connecticut, affiliated with Hartford Hospital, and Dr. David Reichstein, who is here from Tennessee Retina, and Dr. Peter Hovland, who is here from Colorado Retina. So thank you guys for being back here. I'm going to let you guys get into your presentation, which, by the way, is the end of this presentation, I guess, is sponsored by Colorado Biosciences. So we're grateful for them for their contribution. And keep those question cards going and bring them, whoever's in here, Lauren, run those questions up to me so that I can make sure that we can pose those to these guys at the end.
Okay, here we go. This is going to overlap a bit with what Dr. Reichstein's last talk was about. This is my take on some of these issues that occur after you've been treated, the radiation side effects. And anyway, thanks again for being here. Appreciate the opportunity to address you guys, and want to let you know we get a lot out of this. I hope you guys are too. Let's see. There we go. So this is some data showing that the trends in the U.S. over the last number of decades. We used to remove a lot of eyes, and now we don't remove as many. Radiation allows you to conserve your eye and your vision potentially. So radiation is, probably 90% of patients are being treated with radiation. How do I advance it? That little? Seems to be going slowly. Okay, so we sometimes call radiation treatment conservative therapy. That means you get to keep your eye and preserve your vision, as well as the cosmetic effect of keeping your eye. Proton therapy, we just talked about earlier, it's used less commonly, but plaque brachytherapy as well can cause similar damage, or what we call radiation retinopathy, or radiation causing other effects besides effects on the retina. It can damage the normal eye structures, and the higher the dose of radiation, the more likely it is it will cause the damage. It also depends on the size of the tumor is, if you have a larger tumor, you're going to get a larger dose. It also depends on the location, as we see, the closer to the nerve or macula, the more likely this is to affect your vision. Brachytherapy we talked about. This is my picture, just like Dr. Walker had the plaque there behind the tumor. We can see in the black and white on the right there, there's a plaque behind a tumor. You can see a little detached retina beneath it. But we like to use ultrasound, and the difference between, or to guide it, the difference between this and the protons is that the radiation effect is coming straight out of that plaque. So the highest dose is hitting the tumor, and the term dosimetry refers to the dose fall off as it goes away. This is working really in a delayed fashion. I'm sorry, throwing me off. I'll just say next slide. In any event, the color drawing shows how the blast zone radiates away from the tumor, and the further away from the tumor, the smaller the dose to the tissue. And I think that great eye plaque diagram that Dr. Walker shows we're really paying a lot of attention to what structures are involved, but we really don't have a lot of choice. We've got to treat that tumor. Next slide, please. So after treatment with radiation, again, I'm repeating points that have been said earlier, but I get it all the time. There's no radiation left in your body after that. I've been asked half a dozen times, people say I've got cavities in my teeth, is it because there's still radiation? And the answer is no. But we do think that the damage to the tumor is instant. It goes in there, destroys the DNA in the case of plaques, and that the tumor's no longer able to grow, or more importantly, not able to metastasize. And that's what we call local control, meaning in the eye. It may take months to see the tumor respond to the treatment. Next slide. And we saw the importance for follow-up. The damage to the local tissues might show up sooner, but typically it takes a while. And more often than not, it's over a year before the radiation damage will show up. in the healthy tissues. So there's various ways to treat radiation side effects. Medically, we could use eye drops. Sometimes steroids are enough to help alleviate some of the issues. But as we've gone into it, we understand there's a role for eye injections. How many of you guys are getting eye injections right now? About half of you, it looks like. So this is how you preserve not only your vision, but really the health of the eye. Avastin, Lucentis, Eyelid are the names of some of the drugs that can be used. There's probably other drugs that are coming out in the near future as well. I also find that a separate class of medication called steroids that are anti-inflammatory medications are useful. Kenalog, Triessence, Ozurdex are names of some of the drugs that we've used. You might find that you get switched from one drug to the other. Additionally, laser, we've talked about this. Laser can be used to treat radiation side effects. We talked about argon laser, diode laser. I don't think we've brought up PDT laser. That's typically not used very often for treatment of radiation side effect, sometimes to avoid. I'm not going to go to PDT right now. I should have not put that in there, sorry. A treatment of radiation side effects, cataract surgery we talked about. I think it's generally accepted. It's safe to do cataract surgery after you've had radiation. Vitrectomy, that's the kind of surgery that vitreoretinal surgeons like ourselves will do to go in to clean out blood, for example. And then enucleation is still sometimes needed, even after a long course of treatment. Sometimes that's the right treatment. Now, I want to clarify one thing. It sounded like maybe I came off being an advocate for primary enucleation earlier in the day, and I'm definitely not. I think as an ophthalmologist, as an eye doctor, I understand the importance of vision. And so I brought it up in the context to say that we may need to fight for our rights to continue to provide these advanced treatments because vision is extremely important. And that's the value to radiation treatment. It allows you to hopefully preserve some vision. And I found even a small amount of peripheral vision is useful to folks. So it may be disheartening to not have normal vision, but I do believe, from my experience with patients, that any vision is worth fighting for. So, now, we had this earlier. Will I need treatment for radiation side effects? Next click. The answer is probably. I think almost everybody needs it eventually. And so as we're watching patients in the years after treatment, the first year or two is to make sure that the tumor's adequately treated. Usually we have a pretty good sense of that. But we're also fighting for vision. We find you can actually improve the vision in some cases. We've certainly seen that. Sometimes treatment is just designed to prevent or delay vision loss as long as you can. And again, I also think it's just a healthy eye is going to last longer. And if you have a blind eye that's unhealthy, full of blood, the chances that it will become painful and deteriorate and ultimately cause you a lot of trouble are significant. So even for those reasons, even if it's not for vision, I believe treatment of these side effects is important. Next slide, please. So I want to show, we went over the anatomy of the eyeball. Again, I thank you for introducing the concepts. I think the important thing is the macula. That's the center part of your vision. And I like to talk about the front of the eye and the back. So the anterior is the front of the eye, posterior is the back. So when I ask a patient, or I tell my technician, let's do the posterior exam, I'm not asking for you to turn around. We're looking in the back of your eyeball. So here's an example of a posterior choroidal melanoma being treated in a clinic. He's gonna use that in clinic? All right, this shows, there's an animated feature that's supposed to play here. There's the plaque and then the penumbra. There's the radiation effect. And we can see it's actually, that's a pretty good clean plaque there. It's not hitting the nerve, it's not hitting the lens, not hitting the front of the eye. Most patients will fit into this category. But the radiation, go ahead, keep clicking. I'm sorry, I'm used to clicking myself. This is not easy to do here. How does radiation retinopathy work? It's damage to blood vessels. And this reduces the blood flow, reduces the oxygenation, and your retina burns oxygen like crazy. So this will reduce the function, And then, as we've heard, secondary effects will cause macular edema, swelling of the retina. These are very treatable. Next slide, please. So here's an example of macular edema. I have the pictures on their sides just to show what they truly are like when your head is up. Your head is oriented straight up, and the light goes straight to the back. And we'll see that middle picture there, the swollen retina, after treatment with injections can return to a normal appearance and actually improve its function. The edema is actually a secondary effect from the radiation, or even a tertiary, I suppose you could say. This gives you an example here, a picture showing where the blood vessels have dropped out. I don't know if you guys can see inside the yellow circle there. You see all this, what we would call pruning of blood vessels. And this is due to radiation. Now, the tumor in this eye was treated off to the right side, and the blast zone, if you will, of damage extended into the center. Unfortunately, we can't grow new blood vessels there to fix the vision, but we can treat the swelling that develops secondarily to that. Vitreous hemorrhage. Here's a hemorrhage. It looks kind of funny. It looks like a smiling face almost there. The red eyeball is a source of hemorrhage, and it's pooled actually in front of the blood below in what we would call a boat hemorrhage. And this is a sign that this eye is getting ready to bleed a lot more, so we ought to treat when we see this. You can have vitreous hemorrhages, but you can also have, due to ischemia, another condition called neovascular glaucoma. That's a really very serious consequence. Next slide. So here shows a moderate hemorrhage on the left, and on the right we see an ultrasound where there's been a massive hemorrhage in the eye, and as the eye moves about, you can see the blood jiggling a little bit. In my experience, at least half the time you got to go in there and clean it out with surgery. Next slide. Here, this unfortunate patient has a tumor right in his macula. He's just not going to see well. There's not much we can do about it, no matter what we do. There's still a point to treatment, though, however, to preserve the health of the eye. But you can see that goes right into his macula. And he was just mildly symptomatic at the beginning, but unfortunately, we know he's not going to do well in terms of visual acuity. Next slide. Yeah.
In this particular,
Shake it.
in this, whatever. It wasn't that good. Yeah. If you could back up to that slide. No. Okay. Yeah. So there's actually a really good point to treating eyes just like this, right? So the tumor is in the macula, right? But the vision to your left is all on the other side, right? And going across the street, that's visual field that your other eye can't pick up, right? So to see something coming from way out on the other side, that's actually really important vision to try to treat. So the center vision isn't going to be great, but there's a lot of point to keeping up injections and trying to save that vision.
I absolutely agree. I had one guy who worked in a garage, and he could only see a little bit off to the side. That was it. And one day, his eye filled up with blood, and he came rushing in. He said, "I need that vision back, because that helps me from tripping over stuff as I'm going about my work." And we did surgery, cleared him out, and he did well. Go ahead, next slide, please. Here's a diagram of a tumor that's near the nerve, the radiation dose. Go ahead, hit it. There you go. Hits the nerve just because of the placement. We can't avoid it. Next slide. So here's a guy. It is a little hard to point out, but if you look in the left picture on the lower side, that is his nerve all swollen up. It's not the best picture. But after we gave him steroid therapy, his nerve returned to normal, and his vision improved enormously. And this is, I find these, I don't know about you guys, but the optic neuropathy tends to respond fairly quickly to treatment, and it's pretty impressive. It kind of goes away and doesn't come back either. What do you think, Scott?
Yeah, I think we were talking about this earlier. Can you guys hear me? All right. Yeah, the radiation maculopathy tends to be relentlessly progressive. It gets worse and worse and worse as time goes on. But the radiation optic neuropathy is interesting. It's kind of monophasic. You'll sort of hit this point at which the optic nerve becomes swollen, and it's basically analogous to something called an anterior ischemic optic neuropathy, which is like a stroke in the optic nerve. But once you get past that, which may take 3 to 6 months, there's not generally that much progressive nerve damage beyond that point. So I think if you treat it aggressively with steroids to really nurse the optic nerve through that moment in the treatment trajectory, we can potentially save a lot of vision in these patients.
Dave, you see the same thing?
I do, and I think steroid is a much better treatment for optic neuropathy than regular injections. But you got to get it early. You got to get it early, and you hit it hard, and then. But if you do, I think you can make a big difference.
Yeah, I use orals and topicals. So I have my patients eat their steroids and tell them take them in the morning because you don't want to be up all night. But usually a short course takes care of it. But you're right, it can be a long slog, but you generally get through it. People do pretty well. So it's encouraging to see that, the ability to recover from that. Let's see, next. So I think we covered this here. Anterior tumor, here's an iris melanoma. Put the plaque on there. What are we hitting over here? Well, we're not hitting the nerve or the macula, but we're hitting the green, that's the cornea, that's the part of your eye you can touch. And you're hitting the iris, you're hitting the ciliary body, but you're also hitting what we call the angle, which is where the body will drain, internally the eye will drain fluid and maintain its pressure. Next slide. Here's the melanoma of the ciliary body. Similar thing, we're hitting some of the same structures, including the lens. Next slide. So the cornea, I'm going to go through just little specific parts of the eye that can be damaged. The cornea, of course, is the front part. This is usually temporarily after the procedure. On an anterior procedure, you'll see some corneal swelling, but it recovers very quickly. But you can have some damage to that cornea. I think it's pretty rare, I'd have to say, but I've seen it over the years. People that long-term, their cornea can degrade from radiation treatment. Next slide, please. Cataract. I don't know if it looks kind of green on the side there. The patient didn't have green eyes, at least not that bright. But I think you can see can you guys see the melanoma in the top picture there? The upper dark shadow behind the lens in the center. It was a large anterior tumor. We treated it with radiation. And as it kind of shrunk, it left this slithering sort of mark on the back of the lens. And there was a cataract that needed to be removed. We talked about this earlier, but that certainly affects the patient vision. This guy's doing great, by the way. He just got married and just had a baby, and now his kid's most of the way through elementary school, and he's doing super. So the tumor can actually touch the lens. And I have, on a rare occasion, I don't know about you guys, have had a tumor sent in to me when the cataract surgeon was performing cataract surgery and discovered the tumor during the cataract surgery. That's kind of spooky.
It happens.
It does. Yeah. They can be hard to see, those anterior ones hiding behind the iris. Very hard to detect on routine eye exams. Okay, next. So eye pressure, ocular hypertension, can lead to a condition called glaucoma. And it's the high pressure of the eye somehow damages the optic nerve. Normally, your pressure is between 10 and 22. I like how patients will say, my pressure was 15 last time, it's 16 today. Is that a problem? And the answer is no, not really. 30 is a problem maybe. But over time, an elevated pressure can lead to pain if it's acute. But in generally, we worry more about the loss of vision, the damage to the optic nerve, which is unlike the other form of radiation optic neuropathy. Damage to your optic nerve is not typically reversible. You can get high pressures from having a vitreous hemorrhage in your eye, or this thing we call neovascular glaucoma. And the treatment, again, for that is injections and lasers. Now, you don't want to do surgery for glaucoma. This is, I don't know, love to hear your guys' thoughts, but the worry is, there's great treatments for glaucoma, and some of them involve lasers. That's a great idea. But an incisional surgery for glaucoma usually involves putting a drain in the eye. It's like a pressure valve that allows the fluid out of the eye. But the concern is that the tumor cells can get out and deposit themselves behind the eye. I've debated myself whether or not to worry about that, but in general, I found most people won't do tubes. Scott, you're smiling.
I mean, my advice is the same from a medical legal perspective, because some of these tumors are going to spread no matter what we do. If we put a tube in the eye, we may wonder if we contributed to that. So in general, incisional glaucoma surgery is avoided in eyes with a history of melanoma. There are a lot of laser options, and cyclophotocoagulation is a good option for a blind eye that is hypertensive.
You know, this is a topic that I hope that we as a community will start tackling in a little bit more of a comprehensive way, right? Because the glaucoma, so open glaucoma surgery, basically like cutting new holes into the eye to let pressure drain out. That works really well for standard types of glaucoma. In general, we've been sort of averse to doing that in eyes that have malignant tumors in it for obvious reasons. But there's no good reason that we're so afraid of it, right? We're just so afraid of it because we're so afraid of it. So at some point in the future, I hope that, you know, we kind of grow a pair and figure out if this is the kind of thing that we actually can do, because there are a lot of patients who have intractable glaucoma who really could use a tube, and we just say, no, I think we need to either cyclophotocoagulate, which means like you blast it with this laser and it stops making fluid, or you take the eye out. And I think eventually we'll get to the point where we don't have to do that. I don't know if a tube's the answer, but it would be great to start answering that question.
Yeah, I'm glad you feel that way. I do too. It seems like it should be safe to do. You would think the cells are dead, whatever they are floating out. I did talk to a famous doctor in Philadelphia about this, and the concern was, I guess there was a case where they did an enucleation after a glaucoma surgery, and they found cells behind the eye. But I don't think there's been a case of it actually spreading. So it's a controversial area. Well, it looks like I probably should get moving through my talk here and finish up. Probably just a couple more slides here, Dave. Why don't we just shoot on through? So other things to think about, the surgical incisions, we talked about that. Next slide, please. The extraocular tissues, you can have an eyelid ptosis, just from the procedure where your upper eyelid is down. A lot of people have that. I've talked to oculoplastics. It's a pretty quick fix with a little stitch, but so don't be afraid of it. They'll do it for you. They'll fix your eye and balance you out. It is fairly common, though, with a lot of forms of eye surgery, frankly, not just the brachytherapy. Conjunctiva, we see that gets scarred up. The eye can be tight, feel weird, become irritated. You can have issues with dryness. Nasal incisions, the ones near your nose, especially you ladies. You guys are always looking in the mirror at yourself, putting on makeup. And if you look at near your nose, the normal structure is really pretty complicated. And getting that just right put back together after surgery is not as easy as it might sound. Next slide. We talked about extraocular muscles. I found they can adhese to the surface of the eye. They can cause double vision. They can restrict the eye movements. And actually, it's okay to do surgery. Here's a case where you can go back in and, if you need to, have some corrective eye surgery done there. Retinal detachments you talked about. Sometimes we have to repair these. That's okay to go in and do vitrectomy. We see chronic inflammatory states of the eye, and oftentimes steroid bursts are needed a year or two out following treatments. It's interesting. I do believe the eye can go into a chronic inflammatory state. That's been well observed. So steroids actually, strangely enough, I find that after doing anti-VEGF therapy for a few years, I find I need to go to steroids more frequently down the road for management of the eye. I think this is close to the final. So it's safe to treat your eye for these radiation side effects. It's safe to put needles in there. It can improve your vision. There's benefits to it. It can delay the loss. It can improve your comfort. But it may forestall the inevitable. Even after, maybe you can preserve it for 5 years and then you lose the battle. Well, at least that's perhaps 5 years more than you would have had. Final slide, I just want to share. There's a couple trials coming out. You may hear about them in the future, looking at actual trials for radiation retinopathy. Right now, if I go to code and check a box, I'm going to treat you for radiation retinopathy, there is no box. We have to do angiograms and label you guys as having branch vein retinal occlusions, things of that nature. So hopefully by having these trials coming out, we're going to have a system of classification that is used, as well as an acceptance by the medical community that this is its own separate entity that should be paid for in terms of therapy. Next slide. I have to show off the last slide. There we are, a couple years ago in the OR. It's a team, and you guys are part of it. We're part of it, and thank you all for being here. It's good to see so many patients at once. Thanks.
Can I make a suggestion? I wonder if we might take a short break right now, all right, and that we can get the rest of the talks up on the computer, which I think is going to help us click through them from just a logistics standpoint. Maybe, yeah, and then because right now, I think they're being controlled, not from us, but from the back, and because our last session is pretty short, I think we can do the remainder of this session with the last session together.
Yeah, that's fine.
You think that'd be okay? So why don't we take a 5-minute break now? We'll finish this session.
You guys hang out here. This is not a break for you. This is a break for these guys to figure things out. And I will actually run through some important information for those of you here in person.
Yeah, and then we'll finish everything.
Perfect. Next up is Dr. Walter talking about endolaser.
Endolaser. All right, let's pull up the slides. Perfect. So I think in the next couple of talks, we're going to talk about some of the treatment advances for primary treatment of uveal melanoma. As we talked about earlier, plaque brachytherapy has kind of replaced enucleation as our primary treatment for most patients. But as we move towards treating smaller and smaller tumors, I think that we may be shifting away from plaque brachytherapy towards some less destructive treatment modalities as our primary treatment. So I'm going to talk a little bit about my experience using vitrectomy with endolaser photoablation for small melanocytic tumors. So maybe we're going forward, maybe we aren't. All right, so all three of us are vitreoretinal surgeons who also practice ocular oncology. And I think, conventionally ocular oncologists were in their own, field, but I think more and more vitreoretinal surgeons are comfortable managing intraocular tumors. And a lot of you may have been treated by people who function both as ocular oncologists and vitreoretinal surgeons. So the surgical techniques that a vitreoretinal surgeon brings to the table may be very different than the surgical techniques that someone who's trained exclusively in ocular oncology. So pars plana vitrectomy is kind of our standard surgical technique for addressing most issues in the back of the eye, such as retinal detachments, macular holes, macular puckers, removal of blood from the eye. So it's a technique that we're all very comfortable performing, and it's a safe way of accessing structures on the inside of the eye. So we know that diagnostic vitrectomy is part of our armamentarium already as oncologists. It's a standard surgical technique for biopsying vitreous lymphoma and other metastatic cancers to the vitreous. And it's often our preferred technique for biopsying choroidal melanomas, specifically among those of us who are trained as VR surgeons, vitreoretinal surgeons. So we know that diagnostic vitrectomy can be used in the context of making a diagnosis, but how can it help us therapeutically? So in vitreoretinal lymphoma, which is another extremely rare cancer that we treat, I think it plays a very important role. You're basically removing the lymphoma cells from the eye, and that in and of itself is therapeutic for a lot of patients in conjunction with other therapies such as intravitreal chemotherapy and radiation. So is there a role for therapeutic vitrectomy in choroidal melanoma? So before we get to that, let's talk a little bit about what I mean by endolaser photocoagulation. So this is an illustration of a curved illuminated endolaser probe, which is being inserted through that little port on the outside of the eye into the eye. And you can see that the surgeon is depressing the outside of the eye here and applying laser to the retina. And this is done in retinal detachment surgeries, in diabetic vitrectomy surgeries, in order to create an intentional burn of the retina. And the way that works is that the laser energy gets absorbed by melanin, which is the pigment in the liner underneath the retina, and then the laser energy is dissipated as heat to the retina and the choroid, which are sort of the tissues immediately adjacent to the retinal pigment epithelium. And this causes a burn in the retina and ultimately tissue death that leads to a scar that seals the retinal hole in the case of a retinal tear or detachment. So that's kind of how conventional endolaser photocoagulation works. Basically, heat stress leads to necrosis of the tissue and cell death. So how about photoablation for choroidal melanoma? So basically, same concept. The melanoma contains melanin, which is the same pigment that's in the retinal pigment epithelium. So it makes sense that the melanoma would absorb the laser energy, dissipate that energy as heat, and the heat stress would then lead to death of tumor cells as a result of the application of laser to the tumor. The potential advantage of treating with laser is that it's a more targeted therapy than radiation. There's really a very small field of damage. It's very targeted. So there's less damage to the surrounding retina. So potentially we could be a little bit more targeted in our therapy with laser than we can be with radiation, which has this wider field of collateral damage around the treatment area. So Tim Murray, who is an ocular oncologist and vitreoretinal surgeon, and actually probably one of the most preeminent vitreoretinal surgeons who practices ocular oncology. He was recently the president of the American Society of Retina Specialists. So he gave a very interesting talk at this year's meeting of the American Society of Retina Specialists in the Ocular Oncology Symposium. And he was basically arguing that small class 2 melanomas can be effectively treated with this type of therapy, directly ablating the tumor with laser without the use of radiation. This is, of course, a single center experience, and I think that you know, the fact that someone who's so prominent in the field is willing to kind of put this out there as a potential treatment option is a sign that we should really be thinking seriously about who this may make sense for. So what are some of the potential limitations? So the wavelength of the laser that we used in endolaser vitrectomy is shorter than the wavelength of the TTT laser. So the TTT laser is 810 nanometers, whereas the endolaser is 532 nanometers. And the reason that makes a difference is that the wavelength of the light actually affects how deeply the tissue penetrates, or sorry, the laser energy penetrates into the tissue. So that's why you may have heard us talking earlier about TTT as a good treatment option for thin tumors, maybe tumors less than 2 millimeters. It's possible that, you know, the limitation on size may be even greater for this endolaser, unless we can figure out how to hook up an 810 nanometer wavelength source to our endolaser probe, which to my knowledge is not currently available.
Actually, there's a guy doing it, Scott Oliver at the University of Colorado.
Yeah, I think that's a great idea to try and incorporate that 810 nanometer wavelength. I lost my slides there. So anyway, my current perspective is that this is an effective therapy for small extrafoveal melanomas. So if the melanoma is in the fovea and you laser the fovea, you're going to have instantaneous vision loss. So we obviously don't want to do that. And I personally reserve it for tumors with a genetically low risk of metastasis. So the class 1 PRAME-negative tumors, I'm comfortable treating with this. I'm not yet comfortable treating a small class 2 tumor with this modality unless we have, you know, really well-designed prospective data to support it. So I think in the future, this should be evaluated further. A lot of us are using this in select patients, and maybe a multi-center meta-analysis would allow us to establish a better consensus in the field about when this is an appropriate treatment. And I think once we've done that, the next step would be to have a randomized prospective clinical trial to really determine the efficacy in preventing metastasis, particularly in higher risk tumors, and establish, the safety profile of this treatment. So that's it.
I think it's a great idea. I think there's a role for it. Thanks for presenting.
I completely agree, Scott. I think this is a great way to start, especially if you're vitreoretinal trained, and if you have a small tumor, then knowing that you can have focused therapy, but also choosing your patients wisely, I think is a really good way to start. And you always have radiation, to back yourself up if you need it.
I thought it was important to note the difference, because I had no idea there was a difference between TTE and endolaser. And so just specifying that difference so that it's not just, maybe from the previous discussion that we had about like, well, no, we don't want to just do laser. It's like, no, there's a specific type of laser, and one laser might be better than the other, or really is better than the other, and the other one should be used simultaneously or, kind of in conjunction.
When you're in the operating room, you have the chance to get right up on top of the tumor too, and you can be a lot more. I think you have the opportunity to be a lot more aggressive, to be to laser the tumor and do it in a much more focused way. And doing it in the office can be extraordinarily painful. And there are patients in here who are my patients who will concur with that statement that, if you really want to laser a tumor hot, it can hurt a lot.
Yeah, no, that
and it's
makes
tough
sense.
to numb up the eye in the office.
Well, that's an important distinction too. TTE can be done in the office, endolaser can only be done in the operating room.
Piggybacking on that subject is something I've been doing recently, and that's endoresecting the tumor. We talked a little bit about this in certain cases where we talked about recurrence of the tumor. What I've been doing is using, well, I don't really have a pointer, do I? Oh, yeah, I do. Using the vitrectomy setup, I will enter the eye, then mark the tumor with what's called an endodiathermy. This is a basically strong heat at the edge of a probe that I can put inside the eye, surrounding that tumor, and then taking the endoprobe, making a little incision in the top of the tumor, using my cutter that I would take vitreous out, take that, and then just start cutting the tumor down to the wall of the eye. What we do then is there may be like little pieces of tumor that are sort of stuck to the wall of the eye left behind. I have a forceps that I can use to remove those, and this can be done as sort of a complete primary treatment for the primary tumor. Because we have to go through the retina down to the back of the eye, we've created a retinal tear that has to be fixed, either with a gas bubble and laser that we put in, or sometimes we put in silicone oil. These are some of the examples of patients that I've done it on. I've learned that there are good patients for this technique, and there are not so great patients for this technique. The good patients are relatively small tumors that aren't right in the center of the vision, right? And it helps for me to be able to approach it with my right hand. So it's a lot easier for me to approach the tumor if I'm using my right hand on the temporal side of the eye, if it's in the left eye, because I'm coming from here, my right hand, I'm right-handed. I go that way across the eye. then I can approach that area much easier. Or if it's a patient's right eye and I'm right-handed, that it's the part towards their nose. All that makes the surgery a whole lot easier. And there are certain patients that it works great for. One is small peripheral tumors. The other is patients who have previously been radiated. I use it in 2 cases here where we've used it as a treatment for recurrence. It's also great when done if the patients have vitreous hemorrhage, a bunch of opacities inside the eye. And then I've learned who not to do it on, right? Patients with a lot of subretinal hemorrhage underneath the retina. And those patients have ended up with some really severe recurrent retinal detachments. That was a learning process, but this is I think, for me, the next step in how to treat small tumors and also in areas of recurrence that I may not want to re-irradiate.
Hello? Hello? Very interesting. I noticed you had the GEP type on all of these. So did you do the biopsy at the time of the endoresection?
I did biopsy at the time of endoresection, yeah. If I was using it as a primary therapy, yeah. And so I would remove the tumor, endoresect the tumor, do GEP. At the same time, I would, also send cytology since I had tissue I could send. And then if the tumor was highly aggressive, I would go on and radiate it.
I've done endoresections, but only on previously plaque patients, tumors that were recurrently hemorrhaging, for example. The tumor tissue I found was really quite rotten, and removing it was the best solution. Interesting. What do you think, Scott?
Have any personal experience with this technique. I can definitely appreciate the PVR risk, making a large chorioretinectomy scar, which could potentially lead to issues. But I think it may play a role, in local control for the right patient.
I think we can move on now to.
There's a European Spanish doctor that does this very frequently. His videos are crazy. He goes in there and just
They do it a lot in
these-
Europe. They do it a lot in Europe, yeah. Yeah. Sure. Yeah. Why don't we take some questions now?
A couple of the questions that we had that came in that were more relevant to what we've just talked about. Can you just, I guess, maybe dumb endoresection down into layman's terms? Because I think I can say what I think I'm hearing, but I just want to make sure that that's what you guys are saying. So can you maybe dumb it down to layman's terms for us? What is it?
Sure. So basically going inside the eye, removing the retina over the tumor, and then cutting the tumor out with a very fancy sucker.
So this is like we're talking about, this is a new advancement in this treatment for cancer as an option for using.
It's a new theme on an old treatment. So it was in favor for a while. Then as plaques got a little bit better, people got away from using this technique. Myself and others, especially not in this country, but myself and others are using it more and more for a certain select group of patients.
Okay. So the study mentioned that, I can't remember if it was, I can't honestly remember which of you mentioned it, but the study that was mentioned from ISOO about the predicted outcomes of the smaller class 2 patients, that if it was treated earlier, it was found to have a better outcome. Was that all types of treatment were studied, or was it only specific? Was it brachytherapy, proton beam, and the endolaser, or was it only endolaser? And if you don't remember, you can point us to the resource for where we can learn.
I can't say I know what you're referring to.
Tim Murray's study, which was presented at ASRS, included a variety of treatment modalities. His basic conclusion was that early definitive treatment of a class 2 tumor is is potentially curative. And I think that we've seen that in the retrospective data as well. So Bill Harbour and I did a study a few years ago where we looked at 2 large cohorts of patients with class 2 melanoma and tried to find a size cutoff at which treating the tumor was likely to be curative. And basically in both cohorts, we validated a 12 millimeter size threshold. So basically, if we can effectively eradicate the tumor before the basal diameter reaches 12 millimeters, even if the genetics of the tumor are quite aggressive, we have a much higher likelihood of preventing metastasis.
And that holds up, from when even before there was genetic testing available, right? One of the studies that I like to cite is a millimeter by millimeter thickness analysis that was done by Carol in 8,000 patients. And what she found was that essentially for every millimeter increase in thickness of a melanoma at the time of treatment, your risk of metastasis goes up by 5%. So a 1 millimeter tumor by itself without any other information has about a 5% risk of metastasis in the future. A 10 millimeter tumor without any other information has about a 50% chance risk. So
information some of us may like and some of us may not want to do that math.
Right. I think the
But
point
the
is
doctors
the
can
smaller
do that
the
math,
better.
and you guys understand that, so that's the important thing.
Well, I think this is really the issue. I mean, a few years ago, I was at a meeting, and one of the doctors, a famous doctor from New York, said, "Do you think we are affecting anything by treating the eye?" And I think this is where we are. There's some hope that if we get them early, we can help. But sadly, too often the way we properly interpret the genetics is that by the time we've treated the eye, the cells in the high-risk patients have already spread, and we just can't find them with the PET CT. We may not know for years. But for example, class 2 or a VAP1 mutation, we think that the cells, by the time we meet you the very first time, those little cells are already out there. And even if you get a PET CT scan and you're clean, they're probably out there. And that's what that means, being a high-risk patient. Mm-hmm. It doesn't mean that the local control failed. We can enucleate you. That was the COMS study. We can actually just remove the eye and the tumor, but the risk of metastatic disease is still there due to the
micrometastases.
It's the intrinsic property of the cells. The tumor, a class 2 tumor is different than a class 1 tumor.
Yeah.
We had a couple questions from the back.
Can we make sure we get a mic on them?
Right.
Hold on. Okay, so her question is, why are a lot of surgeons saying, well, let's just wait and watch and see what happens for this small nevus that we think might be melanoma, but maybe it isn't? I think Dr. Walter and Dr. Hovland, and you all have an opinion, I can tell.
I mean, my feeling is that, I'm trying to phrase this in the best possible way. My feeling is that it's not too likely that by the time you come see one of us, that there's really a question about what's going on, all right? By the time you've gotten to one of us, someone has had an inkling that what you have is a melanoma, right? And in that case, you're probably going to leave that visit with a plan about treatment, right? 95% of the time, when somebody comes to see me and there's a question that maybe it's a melanoma, they were right, and we're going to treat it. And so I don't love prolonging that process and waiting for it to grow a little more so that I can be more convinced. That being said, right, there are lesions that you don't want to treat, right? And that and that they may be really vision threatening, right? And you know that the results of what you're about to do to somebody, right, have
It's like the
very
idea of do
significant
less harm.
consequences, right? Have very significant consequences. And so you do want to be sure. But I think those moments, at least in my experience, are becoming less and less common.
Yeah. So, and I mean, could there be some argument here that if that is happening, or you know a patient that's happening to, that person should seek a different opinion at that point if they are feeling like they're being watched and waited and they don't like that?
If I could jump in. I think there's a historical context here too. Back in the days when enucleation was the only option in the 70s, the standard of care was watch that smaller lesion, if you will, to make sure you know it's a melanoma before you remove the eye. Mm-hmm. And I find that still, I guess I feel a little bit differently, Dave. I seem to be, the obvious melanomas are obvious. The ones I struggle with are the ones that are, gee, did this thing grow? It wasn't seen before. It's got orange pigment, a little fluid, but it's less than a millimeter thick, and it's 6-7 millimeters in diameter. And then, should I watch this or treat it? And you almost feel like if you watch, and then 3 months later you say, it's growing, you feel like, gosh dang it, I should have treated it 3 months ago. So should we err on the side of over-treating these things and jumping and getting on board? Or should we be watching these things? So
I have a question. I mean, does Dr. Walter have anything that he would weigh in on that as far as the early biopsies can go? I know we've kind of talked a little about that before.
Yeah, so I mean, most patients fall into one of two categories. Either it's, pretty obviously a nevus that we can watch, or it's pretty obviously a melanoma, which we need to treat. But there are a substantial number of patients that fall into sort of the gray zone in between, where it's sort of a clinically suspicious but small tumor that has some risk factors or features that are, suggestive of melanoma, but I can't really tell from looking at it whether it's a melanoma or not. And that's where I think that an early biopsy can help guide the next steps in management of that patient. So these sort of suspicious, clinically indeterminate, smaller tumors, I will often biopsy and treat with the endolaser photoablation if it's in an area where we can, spare the vision. So at least we've done something to treat the primary tumor. And if it comes back class 2 or BAP1 mutation positive, I'm going to convince that patient that they need plaque brachytherapy on top of my treatment. But if it comes back class 1A, PRAME negative, I'm more comfortable observing a lesion either, with the laser therapy or in some cases without any therapy, if we know that therapy would be visually damaging to the patient.
And I think we're in complete agreement there. Is that we have a lot more things in our armamentarium now than we used to. Right, and the fact that we can biopsy and biopsy safely before moving on with brachytherapy or with proton beam or whatever is, it's a really significant arrow in our quiver.
I must admit, not to prolong too much, but I have seen a few lesions, most typically ones that surround the optic nerve completely, where you're going to be blinded no matter what if we treat you. And I've had patients dig in their heels and say, I want to wait. And I've got a few of them I've been watching now for 8 years or more, and it never did change.
Oh, and if the patient has a strong opinion about it, that's an entirely different situation. So your question about should the patient seek an alternate opinion, the answer to that is not necessarily. Because there's nothing stronger than a really good, committed relationship between a doctor and a patient. So that is at the top of really the treatment food chain. If you can really create a trusting relationship between between your patient and your doctor. So anything that we say up here, if you feel really strongly about how you're doing with your particular doctor, always comes in second place, But this is actually a really good segue to our next discussion, which is on the topic of what we used to call AU011, and it's a treatment for a novel treatment for primary tumors that are small or indeterminate or growing. And this is a treatment that's brought to us by one of our sponsors, a company called Aura. I should disclose that I've been asked by Aura to deliver this presentation. I've contracted with them to do so. I'm an investigator in the Aura clinical trial, and we're going to talk about some of the data that's come out of that for small and indeterminate lesions. So what this is, you need to think about ways that stuff gets into your body, okay? Ways that stuff gets into your cells. And one of the ways that stuff gets into your cells that we've talked about a lot in the last 3 years is through a virus, okay? And so what I want you to think a little bit about this treatment is we've attached a molecule to something that acts like a virus, all right? That virus then gets into your body. It's a safe virus. It's like a safe-ish virus. And then attaches to cells that it targets specifically, okay? So this is like a little bit of a complicated concept, okay? This medicine can find cells that are specific to cancer, all right? And along with this thing that acts like a virus is a molecule that attaches to that tumor cell, okay? It's a targeted therapy with multiple potential sites of cancer within the body, the most pertinent of which today is choroidal melanoma. And this molecule, all right, which we're going to call Belsar, previously always called AU011, all right, is an investigational novel therapy which attaches itself, when you inject it into the eye, attaches itself to melanoma cells, all right? And if you activate it with a certain wavelength of light, that can have two effects on those tumor cells. One is it causes it literally to just blow up, okay? Or it attracts your immune system, your own immune system, to that cell. Danae, you may want to turn off your microphone.
Yeah, turn your microphone.
Attracts your own immune system to that cell and causes it to kill it, all right? What this allows us to do, okay, we make the assumption that every lesion is like a little bit benign. Every lesion that's malignant is a little bit benign and a little bit malignant, right? This has the potential to attach itself just to the malignant cells within that lesion, okay? Then you light it up, it blows those cells up, it gets a scar, and you've treated the primary tumor, all right? That's really the thought behind how this works. The medication is either delivered by an intravitreal injection, which a lot of you are familiar with, okay, or by injecting into a space called the suprachoroidal space, which is between the eye wall and the choroid, all right? The choroid is where these melanomas occur, all right? And then there's a special wavelength of light that we use to excite this medication, and then it goes on to killing the tumor and sparing you the potential side effects of radiation. And several of us you've seen today have been part of the investigator group that are looking and evaluating this tumor. I'm one of those people. We're going to talk a little bit about some of the data. So what we should say initially is that this was the kind of trial that you could go into and know exactly what you were getting, all right? Not a lot of trials are like that. A lot of trials are masked, where you don't know what you're getting, the investigator doesn't know what you're getting. This one, you knew exactly what you were getting, all right? You had to make the conscious choice that you were going to get this experimental therapy, all right? And initially, the treatment was just for small melanomas that we decided were just melanomas by looking at them, all right? You came in, you saw an ocular oncologist, we said, this is a melanoma, and then we treated it, okay? As time went on, that the people that were included were really just people who demonstrated significant growth measured by photographs or by ultrasound, okay? These were the clinical endpoints, right? We watched the tumor size grow or not grow, all right, as measured by ultrasound, and we were also particularly interested in visual acuity with the hypothesis that if we could treat these tumors with this novel agent, we would save patients some vision loss. What we found was that you could prevent tumor growth, okay, by using this medication that you excited with a laser, all right? The highest effect, meaning the least tumor growth, okay, what we were looking for is no growth or minimal growth. The highest effect was seen the more times you used the medication, okay? So you injected more, you lasered it more, you injected some more again, you lasered it more again, okay? And if you did that enough times, then you would get a significant response, okay? This is an example of a patient who was in the study, all right? You can see on the left side of the screen a lesion that was initially described as indeterminate, watched it over the course of treatment, watched it 3 months later at least, and they saw that there was significant growth. And this is exactly the kind of person who has done very, very well with this investigational product. You watch them over the course of their treatment. They didn't keep all of their vision, right? So their baseline was 69 letters. They kept 56 of them, all right? Which is actually a pretty good amount of vision. In most patients, the vision was preserved, okay? The most interesting thing is that even when the tumor was near the optic nerve or near the very center of the macula of the fovea, they had minimal vision loss. And these are exactly the kind of people that we worry about with vision loss for radiation retinopathy. Commonly, patients would develop some inflammation in the eye, okay? The lesion, the medication seems to draw the immune system in, all right? So getting inflammation inside the eye was a common thing. After you got over that, you started getting a lot of vision back. So the next way that, so that was the initial set of trials, okay? More recently, the company has been focusing on getting medication into the eye through the suprachoroidal space, okay? And what this is it's like a teeny tiny sliver of a space. We call it a potential space, all right? Because it's between two tissue layers that you can open up if you need to. And we're going to show you a video of that. What this potentially does is increases the amount of medication that you can get into the eye and reduce inflammation. So this, I don't know if we can play the video, but if we can, yes we can, is how the medication works. So there is audio along with this video. I don't know if, anyway, you depress the into the eye. This teeny tiny needle will go into the suprachoroidal space, all right? You inject the medication. It increases the size of the suprachoroidal space by injecting medication into there. And then that sort of goes around the eye, and a lot of it then gets into the tumor. As time has gone on, more people have been enrolled into the trial. And so what we started with was a very small amount of medication, exciting it with one laser, right? As time has gone on, we've found that more medication can be given safely, excited more times. Right now, patients are getting the highest dose of medication that we believe is going to be necessary, and exciting it 3 times. And so the therapeutic regimen is completed in 3 treatment cycles. So you get some medication, wait a little while for it to go around in the eye, use a laser, then wait 30 minutes, and then laser it again. And 1 cycle of treatment consists of 3 weekly treatments of this medication and laser. The tumors that we're focusing on, again, we're not biopsying these particular tumors, okay? So the patient knows that we're watching these, looking for actual documented growth. These are the patients that we're looking for to confirm that they're melanoma, so that there can be no question that what is happening is we're treating melanomas. In those patients, what we're finding is that the current therapeutic regimen, getting 3 cycles of treatment, has demonstrated really consistent and significant tumor stoppage, meaning it's not growing. Again, we've seen that there's been a significant preservation of vision, even when there's at the highest dose regimen. And again, the main risks of the treatment have been inflammation. Once you got over that inflammation, sometimes with steroid therapy, sometimes for observation, that's when vision really started coming back and you were doing well. The medication is going to have other potential uses in ocular oncology, so not just choroidal melanoma. It also appears that if you have a choroidal metastasis from a tumor like a primary breast cancer or a primary lung cancer, this will also be an effective therapy as well. And we can see that we can inhibit tumor growth and prolong survival, especially when it's given along with other therapies. So the early work, the preclinical work, along with our current stages of our trial are demonstrating that this is a potential treatment for ocular cancers, especially ones that start in the choroid, choroidal melanoma, and those that metastasize to the choroid. They can be done along with other therapies, other immune therapies or chemotherapy for other cancers as well. Right now, the current pipeline is for use primarily in choroidal melanoma, but we think that there's a potential for other tumors as well. And one of the current trials is for use of the medication in the bladder, actually. Happy to take questions.
Yes, I'm back up. All right. Okay, so my question, when you were talking about the procedure, the staging of, okay, we administer the AU01 drug, and then we laser like 4 to 6 hours, and then we laser, and then wait, and then laser again. What specific type of laser are you using? Is that the endo laser you discussed towards the last presentation, or a different one?
It's a laser much more similar to what you would see in somebody's office,
Okay.
but it's at a slightly, so lasers are made with specific wavelengths, okay, of light. This specific laser has a very specific wavelength of light that we use for this particular purpose. We don't use it for other purposes in ophthalmology right now.
Okay, so then my other question is, you mentioned it's being used to explore other cancers, and that's wonderful. My question is there room within this study or future studies that you can see or foresee to research this drug, you know, in researching its treatment of larger choroidal melanomas, or, you know, medium-sized, large, or even other types of uveal melanoma, choroidal, ciliary body, conjunctival?
I think your question is theoretical, and what I would say is right now the primary indications are the primary purpose of the medication is to demonstrate that it works in treating smaller indeterminate size lesions, and then see what happens.
Okay. Okay, so as we kind of shift gears to the next slides, just keep in mind if you guys do have questions, please write them down on the pages. Keep in mind, again, these physicians are here, but they cannot offer specific medical advice. We know it's so tempting to want to offer all of our specifics, right? Because we are all very unique. But just keep that in mind that if we don't answer your question, it's not because we don't want to, it's just because they cannot. So thank you again for being here, and we're gonna move on to our next presentation with Dr. Walter, and he's presenting for Castle Biosciences, who is our presenting sponsor.
All right, well, take it away. I think this is the last talk of the day. So we're going to talk about genetic testing in ocular melanoma, or more specifically, uveal melanoma. I don't have a disclosure slide, but I am a participant in the COOG-2 trial, which is sponsored by Castle Biosciences, and I have served in an advisory board capacity for them, but they had no role in the construction of these slides, so these are my own thoughts. So my other title for the talk is Decoding the Ocular Melanoma Alphabet Soup. So there's a lot of abbreviations on here, some of which may be familiar to many in this room, but there's probably, I would guess that most people in this room can't explain what each of these acronyms means. So hopefully by the end of today's talk, we'll all be a little bit more familiar with each of these alphabet soup particles. So the evolution of genetic testing, follows our understanding of the genetic basis of uveal melanoma, which has really evolved over time, and it's been driven by some great clinician scientists, two of whom are listed on this slide. Dr. Bertil D'Amato, who in the 1990s kind of pioneered our understanding of chromosomal changes in uveal melanoma. And then in the 2000s to the present day, Bill Harbour, who's one of my mentors, has really kind of taken the field another great leap forward in helping us understand gene expression profiling and the mutational changes that are occurring in these tumors. So if we think about levels of genetic testing, we can also think about the levels of the human genome. So there are 46 chromosomes in the human genome. They're all 22 of them are pairs, and then you have an X and an X, or an X and a Y, so that gives you a total of 46. And on those 46 chromosomes, there are approximately 22,000 genes, and from those 22,000 genes, we produce approximately 140,000 RNA transcripts. And the RNA transcripts are the actual messages that the genes send out that lead to the production of proteins that actually affect the cellular biology. So if we think about these different levels of the genome, we can think about levels of genetic testing at each of these genomic levels. So MLPA looks at the chromosomal level, NGS, or next generation sequencing, looks at the gene level, and GEP, or gene expression profiling, looks at the RNA level. So these are all different levels of the human genome that we're looking at. And as we have kind of gone from this higher order of the chromosomes down to gene expression profiling, you can see that we're with the chromosomal analysis, we're looking at a larger percentage of the human genome, 17%, or 8 of the chromosomes, but we're looking with sort of, a foggy telescope, right? We can see a little bit of what's going on, but at the chromosomal level, but we can't really see what's going on at the individual genetic level. Whereas as we hone in on these genetic signatures and RNA signatures, we're really being much more targeted and specific in the types of information that we're extracting from the tumor DNA. So we're really only looking at less than 1% of the genome when we're analyzing it with next generation sequencing or gene expression profiling. So the evolution of genetic testing has been pioneered by two companies in particular. Castle Biosciences introduced their gene expression profiling test and made it commercially available in 2009, and this followed on the footsteps of Bill Harbour's work in the lab. Impact Genetics introduced their multiplex ligation, I can't even pronounce, MLPA NGS testing in 2014. And then Castle Biosciences expanded their testing offerings in 2016 and 2018 to add PRAME and next-generation sequencing to their uveal melanoma diagnostic package. So we're going to now talk a little bit more about these different aspects of genetic testing. So MLPA stands for multiplex ligation-dependent probe amplification, and this is a technology that's used to detect chromosomal changes. We're specifically looking at chromosomes 1, 3, 6, and 8, and when it says disomy 1, disomy 3, disomy 6, disomy 8, that's normal. That means you have 2 copies of chromosome 1, 2 copies of chromosome 3, 2 copies of chromosome 6, and 2 copies of chromosome 8. That's how your eye was born. The melanocyte has the normal chromosomal profile. Now, if you have an 8q gain, that's a change in the structure of the chromosomes that's associated with an intermediate risk of metastasis. But the big risk factor with chromosomal testing is something called monosomy 3, and then there's a variation on that called isodisomy 3. And both of these are associated with a high risk of metastasis. Patients that have monosomy 3 can go on to develop additional changes, such as loss of the 1p portion of chromosome 1, which can increase their risk, or they can gain 6p, which leads to a slight reduction in their risk of metastasis. So this is kind of the information that is collected with the testing when we're looking at chromosomes. So now let's go down to the gene level or next generation sequencing. It's just targeted sequencing looking at DNA mutations in a specific subset of genes. And I've listed here 7 genes that are included on Castle's NGS panel for uveal melanoma. And we can divide these genes into 2 categories. There's the initiator mutations, and for the sake of simplicity, I'm going to leave out 2 of those and just focus on the more common GNAQ and GNA11 mutations. So most of our tumors, whether they're a benign nevus or a choroidal melanoma, will have an initiator mutation in GNAQ or GNA11. And this is sort of the first step that the cell takes on the pathway to becoming a choroidal melanoma. But it's not a melanoma yet, okay? It needs an additional driver mutation, at least this is our current level of understanding, in one of 3 genes, BAP1, SF3B1, or EIF1AX, to go from a nevus into a melanoma. So there's 2 mutations that make it a melanoma, and one of those mutations is common to a nevus, and one of those mutations is unique to it being a melanoma. So here's just a schematic. We start out with a GNAQ or GNA11 mutation that gives you a nevus, and then on top of that, you get an additional mutation in EIF1AX, SF3B1, or BAP1, which turns it into a melanoma. And it's pretty rare that you have multiple mutations. Like it'd be unusual to have a BAP1 mutation and an EIF1AX mutation. You, generally speaking, only have one of these additional driver mutations in your tumor. All right, now let's talk about gene expression profiling. So this is kind of a more complicated concept. Gene expression profiling uses RNA, which are those transcripts that are being produced from the genes in the genome, to measure the activity of many genes at once. So we can look at the whole genome, or transcriptome, which is 140,000 RNA transcripts, and we get this, kind of messy plot here of, some genes are upregulated, some genes are downregulated in individual cells, and this would vary depending on whether you're looking at an eye cell, or a nerve cell, or a pancreas cell. Every cell has a different gene expression profile, and tumors have a different gene expression profile than the originator cell. So the melanocyte has one gene expression profile, and then as the melanocyte turns into a bad-acting melanoma, it acquires a different gene expression profile. So the way this was figured out was using machine learning, because we're talking about an enormous data set of hundreds of thousands of data points for each individual tumor, and basically, they created this large data set of information from a well-annotated data set of tumors, and we knew that some of those tumors metastasized and some of those tumors didn't metastasize, and we asked the AI, the machine learning algorithm, to tell us what was different about the tumors that metastasized versus the tumors that didn't metastasize. And that's how we came up with gene expression profiling, which uses only 15 different genes, and actually 3 of the genes are what we call control genes. So they're expressed at the same level, whether the cell is cancerous or normal, or a pancreas cell, or a eye cell, or a liver cell. So those are the control genes. Then we have 12 discriminant genes, which are expressed at either higher or lower levels in the cancer cells that were included in this analysis. And what we asked the machine learning algorithm to do was to kind of divide those tumors up into the ones that metastasized and the ones that didn't metastasize, and figure out what was different about their gene expression profile. So you can see here how the algorithm kind of found the differences between the class 1 tumors and the class 2 tumors in the gene expression profile. So what does this mean? If you have a class 1 tumor, generally speaking, you have a much lower risk of metastasis, and if you have a class 2 gene expression profile, you have a higher risk of metastasis. And just to put some rough numbers on this, the class 2 tumors are associated with the highest risk of metastasis. And again, this is old data based on larger tumors than a lot of us had when we were treated. But 70% 5-year risk of metastasis in the class 2 tumors, approximately a 30% risk of metastasis in the 1B tumors, and a less than 5% risk in the class 1A tumors. So again, how does this gene expression profile evolve as the tumor evolves? We start off with a normal melanocyte or a choroidal nevus, which has a class 1A gene expression profile, which is the normal cellular program that a melanocyte should be operating under. And that can evolve into a melanoma, which may maintain a class 1A gene expression profile, or evolve into a more deranged or abnormal gene expression profile, such as class 1B, which is pretty similar to class 1A, but a little bit funky, or a class 2 gene expression profile, which is completely funky. All the genes are, going in different directions than they are. The gene expression is sort of going up when it should be down, and down when it should be up. So that's how we are really defining this line in the sand between class 1 and class 2. So generally speaking, gene expression profiling and NGS provide complementary information about metastatic risk. So if you have a low-risk gene expression profile like class 1A, you're very likely to have a low-risk mutation on your NGS, such as EIF1AX. Again, with the medium-risk tumors, class 1B often associated with SF3B1 mutations, and the high-risk or class 2 gene expression profile is usually associated with a BAP1 mutation. So again, this is just showing us that evolutionary landscape where we're going from the nevus to either the low-grade class 1A melanoma with an EIF1AX mutation, or a medium-grade 1B melanoma with the SF3B1 mutation, or the high-grade class 2 melanoma with the BAP1 mutation. In cases where there's a discrepancy between the gene expression profile and the NGS, whereas some of you in the audience may have had both gene expression profiling and chromosomal profiling, I would say the best thing is to assume the worst case scenario, which is that the higher risk feature overrides. So this patient who had a class 1A gene expression profile, but I identified a BAP1 mutation, I would recommend that she have high-intensity metastatic surveillance and definitive treatment, with plaque brachytherapy or enucleation for this tumor. So what is PRAME? PRAME is sort of a new concept. It stands for Preferentially Expressed Antigen in Melanoma. It was originally identified in cutaneous melanoma. It's what's called a cancer testis antigen. So it is something that's not normally expressed in the eye or really in any tissues except for cancer cells and for some reason in the testis. So there are a number of cancer genes that kind of fall, or cancer antigens that fall into this category. It's not a genetic mutation, so this is important to recognize. This is sort of a gene expression profile unto itself. It's a protein that when it's upregulated affects the transcription of many other proteins. So it changes the cellular program when PRAME is expressed in the cell. It is measured by gene expression profiling, but it was not included on that original 15-gene panel that determines whether you're class 1 or class 2. So the PRAME expression provides independent information from what we get from the gene expression profile. It's not, redundant with that information. The bad news about PRAME is that it has been associated with a poor prognosis in multiple cancer types. So here are some survival curves looking at renal cancer and head and neck cancer. We are currently doing a large multi-center prospective study called the COOG-2, in which we're evaluating the role of PRAME in prognosis in uveal melanoma. But I can tell you from looking at the preliminary data, which isn't published yet, that there is a pretty consistent signal across the board that PRAME increases the risk of metastasis at all levels of gene expression profile. So if you have a class 1A tumor that's PRAME positive, you have an increased risk relative to a class 1A tumor that's PRAME negative. Similarly with class 1B PRAME positive and class 2 PRAME positive, there's an incremental risk on top of the underlying risk that comes from the gene expression profile. So the good news about PRAME is that it seems to increase the recognition of cancer cells by cytolytic T cells, which are the cells that actually kill cancer cells when your immune system recognizes the cancer. And uveal melanoma is notoriously difficult to treat with immunotherapy, but it seems that PRAME-positive tumors may actually be more responsive to immunotherapy than PRAME-negative tumors. So there is, maybe a silver lining that PRAME expression may increase your responsiveness to immunotherapy, and maybe we'll have PRAME-directed immunotherapies in the future that help us more directly target metastatic melanoma that is PRAME-positive. So again, thank you for your attention, and I don't know if we have other presentations or we can go to questions from the audience.
I think we're good to go to questions from the audience.
Yeah, I actually do have a good number of questions, so I'm going to hang out here if that's okay with you guys. Makes it easier. I can see you because my one eye can see you all. It's great. So thank you guys, everyone who's brought in questions. You guys are doing a really good job with bringing these questions and getting specific. If I do have more questions, we probably have maybe 5 to 10 minutes so we can cover some questions. So this is kind of a true or false question. It says, currently, there's no way to find the genetic mutations, really like all of them, BAP1, PRAME, any of these mutations you discussed. There's no way to find them from other blood tests, like a direct body blood test, to find them ahead of time before they metastasize. Is that true or false?
False, but
Okay.
we're not there yet.
Okay.
So the answer is we're working on it, okay? But we're not there yet. And so we are making do with what we have, which is the tissue from the tumor.
Okay. So that was my other question here, is the PRAME evaluation that we're discussing right here, right now, only for the eye tumor primary biopsy, or is it also evaluated at the time of liver metastasis? Or do you guys not know that? I just am curious.
That's a great question. I'm not aware of commercially available PRAME testing for metastatic lesions.
Okay, so this is very specific to just the ocular. Obviously, you guys are ophthalmologists. That is
Right,
very
but
specific.
those patients with metastatic disease in this room are probably very aware of the very regular use of PRAME testing on liver tissue. Mm-hmm. Okay, so at the time of liver biopsy, it's very common to do PRAME testing on that tissue. Sometimes it actually differs from the primary tumor. The reason that may be is because the metastatic liver tissue seems to protect itself pretty well from PRAME testing once it's already spread. So the answer is it's available in both. What we're talking about right now is only eye stuff.
Okay, perfect. So then this one says, can you explain the clinical value? Let's see. Actually, I'm going to read this again, and I'm going to come back and decide if I'm going to read it out loud. So hold on. Are there any current studies that are geared specifically toward the class 1A? Like clinical trials that are, I think you guys talked about, obviously the ARA treatment. as an option, but I think this question is maybe talking more about studies for the metastatic spread, and that one, you guys let me know if we need to defer that to Dr. Moser and Dr. McKean.
I think, they want to do these trials. It's a rare disease. There's not a lot of patients. So most of the trials that I'm aware of have been focusing on the high-risk patients that we know are statistically more likely to develop metastatic disease. And in those, you need fewer patients to determine whether or not your intervention is going to work. So I think the answer is no to that 1A question.
As far as I know, that's correct. If you happen to be a 1A patient who's developed a metastasis, there are clinical trials that are probably available to you just by the fact that you have a metastasis, not because your tumor was
that's a good clarifying question.
not because your tumor was 1A. At the original tumor was 1A.
Okay. Let's see. So are there any studies being done for those who have not been diagnosed yet? So somebody who just has a lot of flashes of light but doesn't have a tumor that's been specifically found? Like, is there any correlation between, you have like lots of flashes, that means you're going to develop a tumor soon? This is a theoretical question, I know.
Yeah, so flashes and floaters are common symptoms from a multitude of retinal conditions, but choroidal melanoma is an extraordinarily rare cause of flashes and floaters in the grand scheme of things. So if you are having flashes and floaters, you should be evaluated by an ophthalmologist or preferably a retina specialist, but you probably are not at risk of uveal melanoma on the basis of that symptom alone.
Okay, I think that covers that. This is a little bit of a backtrack to the previous session, I think. I think this was more kind of from Dr. Hovland's session and what he talked about, but it just says, do you use a slotted plaque for tumors touching the optic nerve? And what is the recurrence rate of primary OM when slotted plaque is used? So basically that gap, where some part of the tumor maybe is not treated directly.
I think the shields have shown that deeply notched plaques is pretty effective for tumors involving the optic nerve. Oh, I do use those. But I would put my data at the anecdotal level, meaning it's not real science or statistics. I would say a lot of it, the plaque, you read these studies, well, there's this kind of local recurrence with this treatment, protons, for example, or with plaques. But honestly, I think ultrasound guidance for a while not everyone used it. And I think without that, you're going to have 20% failure rates we've seen published. So
I don't use it.
Huh?
I don't use ultrasound guidance.
What? Yeah. So I think there's a skill level to whoever's doing the procedure, and it takes a lot of practice. And so I think we try and extrapolate from studies, but the reality comes down to the actual practitioner, I suppose, and the skill at which these techniques are applied. But I think a slotted plaque is a reasonable approach. It has a reasonable chance of success.
All right. Well, I feel like we are down to the end of what we can accept for questions, just for time, to be respectful of everybody's time here. But thank you again to you guys. Do you have anything you want to cover to wrap up this presentation before we go into the end of the day?
No. I mean, if there are no further questions, we do have some comments to make to say goodbye. But
yes, we're going to cover those in just a sec. If you can give us just a minute. We have a script. It's fun. Okay. All right. So. Okay, can we pull up our slides then from the ACIS presentation? We're back to the TriSalus slide. I do need to just take a moment, because we haven't been able to credit them yet, to thank another of our partner sponsors, TriSalus Life Sciences. And they are an interventional immunotherapy company on a mission to improve the lives of patients living with liver and pancreatic cancers by dramatically transforming the way these diseases are treated. So we're grateful to them for their support. Next slide. Our next seminar, if you have not already heard, if you haven't heard it kind of floating around, we are planning to head to Seattle next year. And we're going to be there with the Dr. Stacy and the Seattle Cancer Care Alliance in the fall of 2023. Next slide. Thank you again to our presenting sponsor, Castle Biosciences. If you guys haven't met Kat yet, she's over here in the back. Can you wave, Kat? She's over here. We're so grateful to Castle. This literally would not have happened without them. So we are incredibly grateful for their support and for them being here as well. Castle, they're a huge wealth of resources and they're very open to talking with patients and giving you guys as much support as you need. So make sure to chat with her, make sure you have a good way to connect. And just again, thank you, Tennessee Retina, Dr. Reichstein, for all of the things that you guys have done to help us get ready, to be here, all of the support you've given us today. So Dr. Reichstein, I think, let's see, I'm scrolling down. This is your turn. And if you need the script, let me know.
I have a script with me.
All right, you're good.
So thank yous come actually on multiple levels. Obviously, thank you to the ACIS board, Melody, Lauren, Suzanne, Marlene, Jack, Danae, Julie, and Hannah. Thanks go out to our production team, the WMV Productions, in particular Nick, Philip, and Samantha. Our production team today, that's Paige and Maddie. A lot of thanks goes to the team at Tennessee Retina. Anderson Brock, Dina, Joanna, Holly, Andrea, for not just being here and part of the oncology team, but also taking care of Monica, my daughter, today. To our photographer, Juran Hermestra. And an unbelievable amount of thanks goes to Castle, Aura, Immunocore, Delcath, Trisolus, Foghorn, and Replimune for allowing us to be here. I would love to give my heartfelt thanks to Dr. Scott Walter and Dr. Peter Hovland, who have been here as my compatriots in putting a lot of these talks together. Thank you very, very much. Sincere thank you to Dr. Meredith McKean and Dr. Justin Moser for their time and outstanding talks this morning. Very sincere thanks to Dr. Terry Watson for sharing his experience over on track 2, to Dr. John Pino for talking about low vision. Who else am I forgetting?
Joanna Morales.
Yes.
Triage Cancer, and Ann Osborne.
And Ann Osborne for her amazing story and for providing us all with her fantastic books. And Dr. Afshar for all of that work yesterday. And really, thank you so much for spending your time with us today. I think you can see that we gain as much inspiration out of treating you as I hope you get inspiration out of being treated. This is really our life's work, and the fact that we get to share it in a positive way and come together means a whole lot for us as doctors. So thank you so much. We hope you enjoy the dinner tonight and for being here.